Thank you, Tricia, and thank you, Tim, for a really kind of inspiring sense of the play of digital and technology in supporting quality and outcomes in the NHS. I'm going to be a bit indulgent, if I may, at the start, and just reflect for 2 minutes on my journey, but in so doing, I guess, reflect on your journey as individuals who predominantly are working in the service in trying to drive quality and outcome improvement. And really to start with a thank you. I can only begin to estimate how challenging the past 2 years has been for you in trying to preserve and drive improvements in quality and outcome in what has been the most extraordinary experience that I've had in my 30 years of working in the National Health Service. I'm not a clinician by background. I started off as a health economist and with a focus on epidemiology, but not as a clinically trained epidemiologist. So but more latterly, I've led the COVID response for an integrated care system and subsequently the recovery of services following the COVID response. And the indulgent bit is to recognise that we learned such a huge amount through the COVID and COVID recovery period that we can never regress back to where we were before, but we have to take really measured steps in terms of taking the wins from COVID and deploying them consistently and safely throughout our forward service. And that's really always going to reflect 5 reflections really before I get into the kind of examples that I'd like to share with you today. I guess the first reflection from COVID and the recovery is that risk thrives at the boundary. That's where risk really has its moment. Risk really thrives at the interface between ward and specialty and hospital and partner organisations, NHS and social care. That's where risk thrives at the most. And a lot of the change that we've seen over the course of the last few years has been breaking down those points of interaction and boundary. So COVID was all about breaking down the boundaries between partners in order to give a seamless response to COVID. And the changes that are going on in the NHS at the moment, the establishment of integrated care systems, provider collaboratives, place-based partnerships, they're all designed to break down or to diminish boundaries. And I guess that in that respect, digital solutions are fundamental to helping us to break down and bridge those boundaries and mitigate risk. And that kind of leads on to the second point, is that you all are advocates, I hope, and driving the use of digital solutions in your ward, in your hospital, in your specialty. But we run the risk at the moment of leaping into the digital world and not looking for alignment and simplicity. So where we see the bridging of common provider collaboratives, of integrated care systems, so we have to start thinking about how do we align our digital solutions to be the same across all of those suppliers. The second we start to create multiple complexity of systems, if individuals walking around hospital encounter different approaches around audit and monitoring, or go out of their hospital and go into the community and we have different approaches, it creates innate complexity and in some cases magnifies the risk of boundaries rather than simplifies. So one of the messages we're taking forward in NHSx, and one of the messages that are being taken forward across integrated care systems, are keep it simple and across collaboratives of providers and integrated care systems, start to use common technology, start to use same approaches in order to bridge the divides. So if you are, for example, looking at implementing and taking on new technologies to support your area around quality, safety, audit improvement, my strong ask is that you visit your neighbouring hospitals within your network of providers and you start to look at what solutions they've got, and you start to scale and spread proven technologies rather than necessarily starting to create more complex solutions, because the more systems we have, typically the more boundaries you have, and as we said, risk thrives on those boundaries. Second reflection I've got off the back of COVID is technology is not the answer in and of itself. The answer is the kind of culture, the ownership, the commitment, the governance structures, the clinical passion and ownership for what we seek to achieve. And if we ever believe that technology and digital can replace that, then we are placing ourselves and our organizations, and ultimately the people we serve, our patients, at risk. So never ever presume that that digital solutions replace the heart of the matter, which is great clinicians working together with patients with strong systems and processes and ownership. Having said all of that, the role of digital to enhance that culture, those behaviours, is extraordinary. And that's the sweet spot, is where we are deploying digital solutions to a well-regarded and receiving and enthusiastic community of clinicians and patients. And too often I see technological deployments that don't have the ownership of the clinicians, or are underinvested around deployment to win the hearts and minds of the clinicians and to win, to realise the benefit. So before there's any deployment of any tech, make sure you do your due diligence. Do clinicians own what we're trying to achieve? Do we understand the wins? Are we putting as a minimum 20% investment in implementation support to the price of the technology that we're deploying? So that it's a false economy to try and deploy digital solutions without the investment in deployment support, because it will never realise the benefit that's sold on face value. So never forget that. I thought Tim's point was really profound. I started in the NHS at a time when actually we've always had shortages in certain specialties, but people was never prima facie the real constraint that we faced. You know, we were seeing workforce growth of 3% per annum. Certainly in our acute hospitals, continue to see that level of growth year on year. And we've reached a point of a combination of COVID, Brexit, aging population, a range of other indicators, where it's not a misnomer to say people are absolutely our most precious resource. There's no single doubt about it that people that we have working within the NHS is a single constraining rate limiting factor. And if digital can do anything to free up time for clinicians and staff to reorientate to provide face-to-face patient care, then that is a truly outstanding and necessary aim and goal. And we shouldn't underestimate the fundamental benefit of digital, be it in robotic process automation or in terms of streamlining data collection, in moving from paper-based to digital solutions, voice recognition solutions. All of these, if they are creating time to care for our clinical workforce, they are worth every penny. And we should never underestimate that as a driver. And when our financial directors start to hear about our investment process and talk about non-cash relating savings, and I think we need to get smarter and better about articulating the freed up clinical time and the time to care, because there are, even if we wanted to, there are no clinical staff able to be recruited unless we're paying premium payments over the course of the next 2 to 3 years. So let's get really serious about freeing up our clinical workforce in order to care. And then I guess my final reflection before I do talk about a little bit of the changes coming down the line. COVID's been a game changer, we know that. I think the biggest change it's brought about is the expectation of agility of health services moving forward. I'm talking about you. I've done more fundamental change more rapidly in the last 2 years than probably I did in the previous decade, in terms of the pace of innovation, adoption and evaluation cycles. It's been extraordinary. And Tim used the example of understanding COVID and IPC, and I remember being at the heart of Gold Command trying to make sure we were on a daily brief on what's the latest IPC regulations, what's the spacing between beds, what's the, you know, it was a daily change process. What IPC equipment and PPE could be suited for what, when and how and where. And, you know, it was a roller coaster process, and the innovation, adoption and evaluation cycle moved from months to weeks to days to hours in occasions. And I fear that that's never going to go away now. The pace of our cycling through our understanding of the impact of the implementation is now massively foreshortened. And safety and outcome cannot be a casualty of that. That's kind of the hill upon which we die, is that outcome and safety for people cannot be jeopardized in light of the pace of implementation, adoption, and evaluation. So digital solutions, as Tim's identified, and the perfect word solution, are wards equipped and aware of the guidance? Are they deploying? They become so fundamental because they give you a rapid cycle. It's in keeping with the cycle that we're now operating within. So I think as we move forward, the role of digital in supporting the cycle of safety and outcomes becomes to be clear. So, and just to reassure, those are my 5 reflections. I'm going to go onto the slide deck now. They were more thoughts rather than content. I will now move forward, but I'll probably be more rapid now over the slide decks itself. So next slide, please. So that was kind of the 5 reflections post-COVID of where we've got to. What's clear is that we are now moving to new evolved digital pathways, and you've probably seen a version of this previously. Patient care today, where we have typically a reactive face-to-face treatment-based model of care, where individuals, in order to access, have to choose to access points of interface. We have long waits for appointments, hugely, in some cases, non-value adding outpatient follow-up appointments, and many people now waiting up to 2 years for planned care and not being able to access urgent care in any way, shape or form. So the system is post-COVID has hit a real problem in terms of capacity and access. And digital, as you can see on the right-hand side, provides some of the solutions, not all the solutions, but some of the solutions through which we can respond to that journey. Through how do we support people through digital solutions remaining at home, through monitoring? How do we allow empowerment to individuals to manage their journey through more effectively, and then give them the authority to, for example, choose their point of follow-ups, whether, you know, submit their information and have select their vital signs and clinical information in order to be determined as to whether they do need follow-up or not, rather than being by rote and by typical follow-up process. So we're seeing this fundamental change. Next slide, please. We in NHSx are working incredibly hard to kind of accelerate that process. We're focused typically where the biggest wins lie, on the high volume, low complexity pathways, dermatology, eye care, hypertension, MSK, for example, but not exclusively. And what this slide will share with you is just a few of the examples around where we are deploying digital solutions in order to drive productivity in the clinical pathway. So in dermatology, you can see that we've deploying dermoscopes out into primary care, allowing for a much more efficient means of early diagnosis and management of people with dermatology conditions, and eye care and hypertension. Most of this being around how we deploy early monitoring devices and diagnostic solutions in order to get people through pathways faster, more effectively, and avoid any of the the consequences of late diagnosis and late treatment. Next slide, please. Just a pitch really for where you might want to look at some of the work we're doing. On the NHSx website, you can see digital playbooks, which talk about and narrate the role of digital in a raft of specialties. You see MSK, dermatology, cardiology, cancer, respiratory, mental health, all of which have driven both improved outcomes for people, safer services, but also increased throughput in terms of capacity and productivity of our services. So as you can imagine, we are at the heart now of the elective recovery programme that Jim Mackey is now leading up across the NHS, and the elective recovery strategy has just been launched. We've just invested £250 million this year in a range of solutions around elective recovery, and I'll talk a little bit more of those in a second. But that's just the tip of the iceberg. If I'm honest, we've now seen the spending review, and we anticipate we'll be spending about just shy of £1 billion over the next 2 years around digital investment in elective recovery, and within that we would say solutions which support the safety and improved outcomes for people on the elective care pathway. So I can't understate the opportunities to invest in digital solutions which drive safe and effective care for people on planned care pathways. Next slide, please. And where are those areas that we are focusing the investment? The first is around the more traditional end, which is maximum throughput of the planned care through productivity. And I think solutions such as Perfect Ward, which kind of generate insights into where there are safety, quality outcomes and productivity wins associated with the work you've done, and I'd include in here Get It Right First Time, and some of those solutions are absolutely the heart and centre of where we want and are investing in digital solutions to support care pathways. We're also strongly now investing in additional capacity. In that instance, it's remote monitoring virtual wards. So if we can't find any more workforce to work in a healthcare system, and we're struggling to build more physical capacity, then the next solution is for us to actually use the patient's home as the optimal location. And how do we use digital solutions to remote monitoring, create virtual wards to keep people safely in the home setting, but under the active care and management of clinicians within the health and care system. And then thirdly, the area which is the massively growing piece of focus is around smart triage and patient management. So how do we use digital tools to both equip individuals to make informed decisions about their choices in care? How do we help people to make decisions on their ongoing basis, whether they want follow-up care or whether they want to stay, what kind of decisions they want? How do we use shared care solutions, video solutions, apps and others to help them stay well whilst waiting for planned care access? And how do we support them then preoperatively around consent, self-assessment, whole range of processes, robotic process automation, to take all of the kind of administrative burden from that pathway and speed up the whole pathway in and of itself. So those are the three areas that we're kind of targeting the investment program over the next few years. Next slide, please. And I won't dwell on it, but I think that's a helpful summary slide, effectively narrating the areas that we anticipate we're focusing. And I just pull out one, which is the enhanced recovery after surgery piece, which is evaluated as the biggest return on investment in the NHS at the moment in the planned care pathway. So, and this is effectively that we start from the point of determination of wanting to put someone on the surgical pathway, to get them prehabilitated, to support them with their surgery schools and joint schools in terms of being fully aware it's going to happen. We then manage their fitness before surgery. We manage fluid intake, mobilization. The whole process is driven by a really strict regime of data collection and optimization. And that results in a very significant reduction in length of stay, improved outcome for the patient, and improved non-cash releasing saving for the NHS. So it's a magical win-win-win for all parties. Next slide, please. I've already trailed the digital playbooks, but I would say that they are really valuable reading. They are real-world experiences and learning from organisations across the country, where not just the kind of technology that's been deployed, but the clinical pathway changes that have underpinned that digital enabler have been put forward. And I'm really happy to pick up any questions around those later on. Next slide, please. This is our ambition around virtual wards. We've talked about this being fundamental in the kind of recruitment of workforce, and the building of new facilities is to complement that with creating virtual wards. We started running, if you like, COVID virtual wards during the COVID period. We've got an ambition to ensure that we have virtual wards across every integrated care system this year. Again, I think as we start to see, if you bring back the kind of the perfect ward technology, how are we using perfect ward solutions to support kind of virtual ward technology approaches that are going to be growing in prevalence on an ongoing basis. So I think it's going to be an area of massively growing technology and solution. And we know for elective recovery and urgent care support that the use of virtual wards enabled by digital and enabling technology is going to be a growing feature of the NHS. So understanding how we assure the quality and safety and outcomes associated with patients operating in this space is going to become a growing, and again, an increasingly growing component of how health and care moves forward. Next slide, please. I think the wins are absolutely identified in terms of how we support people at home. And I think, I guess, go back to my previous point and reflection at the start about how are we ensuring that within the deployment of these solutions, which are increasingly accelerating, we are using technology to shorten and circumvent that innovation, adoption and evaluation cycle. So again, happy to answer questions at the end on this area. Next slide, please. This gives you a little scale of the number of people that we are increasingly supporting through some of the digital technologies that I've talked through. And whilst, if you think about some of the overall scaled numbers, so we think by 2023-24 we will see 54 million people in receipt of outpatient appointments. These numbers don't scale against some of those numbers, so GP first appointments, outpatient appointments, etc. But what you can see is, if you tracked the journey of the use of digital solutions over the course of the last 2 years, you'll see that COVID was the accelerant in that, and these numbers we anticipate, although they're fantastic in terms of numbers of patients from April to July, we believe are only going to grow. And the focal point of care, whilst hospitals and community settings are going to be key, the home is going to become increasingly a locus of care delivery that we're all going to have to become much, much more focused and centered on. Thank you. Next slide, please. I just wanted to talk about AI finally as a kind of bit of a focus before we get into the question. So AI is a really fascinating new technology, and we were talking with the British Association of Dermatologists, yes, their acronym really is BAD, about how AI can play a fundamental role in dermatology, and there remains real national regulatory oversight around the deployment of AI and AI technologies, machine learning technologies in the healthcare setting. But everyone and anyone would recognise that AI has an extraordinary opportunity over the course of the next decade to transform our ability to drive improved outcomes, release time to care, and to complement our existing clinical workforce in doing their roles more effectively. And And therefore, you can see kind of in NHSx, we've created the AI lab, and you can see its 3 goals is to both promote the role of AI across the public and professionals, but not lose trust and confidence before we've really got started on AI, and fundamentally to ensure that where we are deploying AI, it's safe and effective, and it's not, it doesn't have some of the early AI characteristics of inbuilt bias and risk processes. So we're being cautious about how we develop and deploy, but recognize its extraordinary potential. Next slide, please. And a few examples, and again, whilst I'm not the expert on this use, we've certainly seen AI around imaging and diagnostics as a massive area of seed, as we know that our workforce in that space are increasingly stretched, that we're beginning to see AI as a tool to support the pace and accuracy of interpretation of diagnostic materials. And you've got there an example around use of AI for acute stroke brain scans, but across the whole of the radiology and radiography field, AI is a massively coming technology which increases the pace and accuracy and minimizes risk associated with the work of individuals in the diagnostic territory. You're seeing it's being trialled across 5 stroke networks in 30 hospitals, and we anticipate that one of NHSx's roles will be to scale and spread that technology moving forward. Thank you. Next slide, please. And similarly, you can see in the lung cancer pathway, you can see how radiology is starting to use the sorting of images and identification of abnormal categories in microseconds compared to the current process of radiologists reading scans as we currently stand. Again, important to state that's not replacing, but it's augmenting the work of radiologists around their diagnostic process. And again, that's the kind of message around technology. It doesn't replace clinicians, but it augments and accelerates the work of clinicians, giving them further time to care. Thank you. Next slide. So the kind of summation, and I'm sorry it's been focused a little bit towards the elective pathway as opposed to the kind of quality and safety pathway, but the kind of key questions and the key reflections right from the outset were, for me, going back to the role that digital and technology is an enabler for the clinical pathway changes you make. It's not a replacement for. Our focus is around time to care and replacing the processes and time that clinicians are currently spending on avoidable processes and technologies, and its opportunity to work to empower patients and citizens to take greater control of their own health and well-being remains at the heart of all that we need to be doing and thinking about. And I'm pretty sure I've seen a few questions pop up that will challenge our thinking in that area. So thank you very much.